Hi, everyone. Welcome back to Guardians of Recovery podcast. Today, we're having another conversation about the illicit drug crisis in Canada. So we'll be touching on things like safe supply, that conversation. We'll get into the harm reduction model and what's working about that, what's not working, as well as we would like it to here in Canada. I'm most excited to introduce you to Adam Zivo. So he's this guy I've been following for the last year or two, reading everything I can get my hands on about what he writes about. He's a fighter, and he's someone that you can always find working towards doing the right thing. He's a columnist for the National Post, and he often explores in-depth investigations into very eye-opening reports on the illicit drug crisis and works on super interesting projects like the war in Ukraine. As well, he's founded and directs Love is Love is Love, which is a Canadian LGBTQ advocacy campaign. So I just love all of that work. I see your commitment, your heart. I see what you're doing to make change, Adam. So I commend you wholeheartedly on that. Welcome to the show.
Oh, thank you. Those are very kind words to say. Likewise, I'm very, I admire the work that you do too. And it's nice to connect with you because together, hopefully we can make some dent in this horrifying crisis across the nation.
Yeah, absolutely. So you've written about everything from the skyrocketing hydromorphone pill seizures in London most recently, to then those disturbing stories about the gang-related drug trafficking. I'm interested in jumping into all of that. But before we start on those initiatives, how about telling us a little bit about your background, what drew you to focus on these topics and issues, and sort of what attracted you to work for the National Post and really reveal a lot of unspoken things about the opioid crisis and safe supply?
Sure. My background is initially in the arts. So I wanted to be a filmmaker and a photographer when I was younger. And I worked in that field throughout my 20s, but also didn't find it as intellectually stimulating as I wanted it to be in many respects. I've always had an interest in policy. And so I went to go do a master's in public policy just before the pandemic. And through that, got a connection with the National Post and basically pitched them. I played the gay card initially. I said, hey, I'm a gay writer. I write about LGBTQ issues from a centrist or center-right perspective. That's hard to find. It's hard to find people who have some community credibility, who come from that perspective, but I had done my activism work. They were into it, and they basically said, yeah, write about whatever you want. We're not going to just put you in the gay box, which was great because I was very used to being put in that box. Mm-hmm. And yeah, I basically, went to Ukraine when the war started. And then while I was in Ukraine, I became aware of the safer supply drug crisis. So my mom is a pharmacist, or was a pharmacist for over 30 years before she retired. And so when I grew up, I would hear stories about the darker sides of healthcare. I would hear about how doctors would overprescribe certain drugs, especially opioids, to make money, and how some crooked pharmacists would assist in that to make money as well. So many journalists seem to have an idealistic perception of the healthcare space. That was never anything that I had any illusions about. And as I started to realize that there was this, big diversion scandal with safer supply that no one was talking about, I realized I had to really jump into this. And I wrote a 10,000-word report about it, which came out in May of 2023. And optimistically, I thought that it would change things, that it would lead to some kind of reforms. But I realized afterwards that the structures put in place to protect this program were really resilient. There was, I think of safer supply as basically being one big scam. And there are a lot of people who are invested in perpetuating this scam, both out of self-interest and many times out of ideology. And at that point, I said, you know what, I really just have to jump into this and see this through, because if I don't do this, no one else is going to do it. And then the kids who I've spoken to, and of course the adult drug users as well, are going to continue to suffer because of this failed program.
Yeah, absolutely. So the thing about it is, like, unless you're someone like me who has lost a child to the opioid crisis, 7 years I fought for Ben's life and tried to, get him help and support at every turn. And, fast forward to when he passed, he had 7 different drugs in his system. Some were prescriptions, some were street drugs, some were, Suboxone, trying to overcome the opioid epidemic. It was just one thing piled on top of another. And his brain was completely decimated. What I was most shocked to see was I wasn't the only person in that situation. Everywhere I turned, there was another parent going through the exact same thing. And what's even more shocking, now that I work in this industry to help other parents, families, and kids, is that this is the common thing with all of the overdoses. Like, the kids are, have so many different drugs in their system when they overdose. And it's like, this systemic conversation is not, we don't have it together. Everybody's working in silos on their own little area and thinking they're doing the right thing. And at the end of the day, the privacy law, the Charter of Rights and Freedoms, all of these things that are supposed to support us as people, and harm reduction, is actually doing more harm than good, and it's killing our kids. So that's what I hope to chat with you about today.
Yeah, it is unfortunate that this space is highly siloed. And while many Canadians understand on some level that we are undergoing an addiction crisis, many people haven't thought deeply about that or what the costs are up until recently, because it was hidden. It was happening to someone else's kids from their perspective, or was happening in a different neighborhood. Only more recently, as crime and public disorder has seeped into other neighborhoods and people are starting to see this in their everyday lives, has there been a larger conversation about what can we do to help these people. It's unfortunate that people don't care until it's right in front of them.
Mm-hmm. And my research shows that we're somewhere upwards of about 27 to 30 overdoses in Canada per day. That's overdose deaths. And then we have another 30 people who are actually overdosing, probably a lot more. Does that correspond with your research?
Yeah, I mean, that's really consistent with the stats that we've been seeing. We forget that the addiction crisis, the overdose crisis, is killing thousands and thousands of Canadians every single year. And in many parts of the subpopulation, drug overdoses are the #1 cause of mortality. For youth in BC, drug overdoses, from my understanding, are one of the top, if not the top, cause of death. Some around like suicide and automobile accidents are like in the competing area, but like really, it is what's killing our kids.
Yeah, it's the #1 cause of death between the ages of 10 and 19. Yep. Yeah. And it's shocking. That is so shocking. I don't know why it's not plastered all across the news every day. I mean, thank heavens for your articles, because you're actually getting it out there at a national level, and we're doing what we can here, through podcasts and social media and stuff. So the tide is starting to turn. I feel a little bit more hopeful than when we first started 11 months ago. But there are just things that are happening that are exacerbating drug use and drug supply getting into, schools, kids, and on the streets. So tell us what you've been able to investigate in that area.
Well, my main area of focus is something known as Safer Supply. So Safer Supply is a program that theorizes that we can save lives by providing drug users with pharmaceutical alternatives to the illicit street supply. So let's say, for example, I get really stressed at the National Post. I get addicted. I start using heroin, graduate onto fentanyl. Now I'm addicted to fentanyl. And when I buy fentanyl on the street, I don't know what's in it. I don't know if it's contaminated. I don't know if it's what its dosage is. It could have xylazine in it. It could have different variants of fentanyl, like carfentanil. If I buy heroin, maybe that has fentanyl in it. It's very unpredictable.
Yeah.
And so harm reduction activists say, well, if that's what kills people, well, why don't we give them a predictable and uncontaminated supply of drugs? And typically that means giving hydromorphone, which is an opioid as potent as heroin, to drug users. But what's important here is that there's two things. So first of all, this safer supply is almost never supervised. So they'll just give, they'll give a drug user a bottle of pills, a very large number of pills, and say, go and take it where you need to take it. We'll trust that you won't sell it.
Right.
And then the second problem is that hydromorphone is not fit to task. So yes, it is as potent as heroin, but fentanyl is 50 times more potent than either of those drugs. So I am addicted to fentanyl and someone gives me a bottle of hydromorphone, it's not going to cut it for me. It's not my drug of choice.
Right.
Even the federal government has conducted research with a report coming out in March of 2022 showing that even maximal doses of hydromorphone will at the most maybe help manage withdrawals for a fentanyl user, but it won't get them high in the way that they want. And so in that situation, any drug user, I mean, if we were in the same situation, we would do the same thing. We'll sell their free hydromorphone at rock bottom prices to make money to buy their drug of choice, to buy what's stronger, because that is the rational thing to do. Because we forget that drug users are still rational. Addiction has hijacked their brain. So what they're pursuing is irrational, but they know how to rationally, well, mostly rationally, seek out the means to that end. Now, here's the problem, going back to youth, which is that if hydromorphone is not desired by more entrenched drug users, that means it is disproportionately going to go to drug users who have lower opioid tolerances, which means people who are new opioid users, people who are in recovery and think that they can handle this kind of drug, or often youth, because youth are more willing to experiment with safer supply for a variety of factors. So one main factor here is that they don't know what it is. So drug dealers will deliberately downplay the addictiveness and dangers of this drug. So they'll be at a party, someone will say, this is a pill, it is a prescription pain medication, don't worry about it, it is safe, it's prescribed by the government, and they'll try it because it's a pill and it's safe and it's very cheap. Just as an aside, 8 milligram tablets of hydromorphone used to sell for $20 a pill. Now they're $1 to $2, maybe $5, depending how you buy it. And they'll take it, and then they get addicted. It's not like heroin. Everyone knows not to try heroin, but if you get a hydromorphone pill, you will try it. And then they get addicted, and then they got to graduate to fentanyl, and then they die.
Yeah. And it's rampant. That is rampant across the country.
Yes.
Yeah. And the fact that you can actually get it for $1 or $2, I mean, that is in the price range of our youth who are going to be experimenting and thinking, oh, this sounds like a good idea at the time. Or, they're out there at parties and stuff, and they don't realize how dangerous and how addictive it is. Like it's inconceivable to me. So it sounds like a great idea at the time, but, what we're seeing is so many of our kids being impacted, and we're seeing this then be sold on the streets and ending up in schools, right?
Yes. And the thing here is that the federal government and the BC government has denied that these drugs are being diverted en masse and ending up in the hands of kids. And part of it goes down to the shoddy evidence base for safer supply. So many of the researchers who support safer supply, they're more activists than researchers. Many of them seem to have a preordained conclusion that they want, and then they bend the science accordingly. And many of the studies which support safer supply are incredibly low quality. So what they'll do is they'll gather, maybe 2 or 3 dozen drug users who are on safer supply, and then interview them about the program that gives them free opioids. And when the drug users say, oh, this program which gives me free opioids is great, it's lovely, it's helping me, of course I would never sell it, or if I do sell it, it's because of compassionate reasons to help a friend, and there's no side effects, then, I mean, obviously there are huge issues and bias here, but for some reason, these researchers never flag that. They pretend that this research is solid, that it is reputable, and in no other area of healthcare would such shoddy research by itself constitute a credible evidence base. And I think that the fact that we accept this evidence, quote unquote evidence, for safer supply is indicative of how little we care about drug users. Because if we cared about them as much as we cared about cancer patients, then we would demand higher quality evidence before investing into a high risk intervention.
I couldn't agree more. And then also there's the point where, like in my experience, direct experience with Ben, the more drugs he used, the less capacity he had to make a life-saving decision. So if we're getting drugs from the government, if we're getting drugs from prescription, he could go to the doctor and say, I'm having problems sleeping. He would get prescribed sleeping medication, even though they knew he was addicted, an addict for many years with a long track record. Then he could go to the streets. Then he could become, a drug mule and sell like all of these different drugs, one on top of the other. When I say his brain was decimated, like he did not have the capacity to make a life-changing decision. And I feel that the onus, when we're giving out drugs, whether you're a doctor or a pharmacy or the government, the onus is on you to prove whether or not that person actually does have capacity or not. And if you can't, then you're contributing to their death, in the case of my son. Because you're giving him another pill that is going to first prolong the addiction. Second of all, we have no idea what the damage is on the brain. Third of all, increasing or exacerbating his inability to not make a life-saving decision.
Well, there's an underlying problem here, which is that addiction policymaking in Canada is very much under the influence of drug use activists. So in Vancouver, well, I mean, to all of Canada, but especially in Vancouver, you have a clique of activists who are active drug users who say that there should be no policy about us without us. So saying that they should have a considerable amount of influence over policies that affect drug users. And essentially what they're doing is they're adapting the rhetoric that was used for equity movements such as LGBTQ rights or racial justice, right? Because when you're making policies about minority groups, really you need to consult them. But drug users are not some sort of minority group. They're not. Unlike a traditional minority group, they just do not actually have the capacity to know what is best for them. Oftentimes,
right.
This is ignored, and so many of the institutions which have so much policymaking influence, they consult with people with living experience. So the active drug users are pushing drug policy. So is it any surprise that our addiction policies are not focused on recovery, are not focused on getting people off of drugs, are instead focused on making drug use as easy as possible? It's not really predictable.
It's mind-boggling to me because, I mean, here in Newfoundland, I don't know anyone who doesn't have a family member or someone directly in their lives or themselves that is seriously addicted. And whether it's alcohol or drugs, whatever substance or both. And, we have super high rate of mental health issues, and a lot of that stems from drug use issues. And I don't understand why there's such a willingness to accept all of this and just not only accept it, but I guess invest in the whole conversation of safe supply. Like Ben lived in what we call a low barrier shelter. It's basically a drug den is what it was. 9 men to a room. Everybody's on drugs, no programs of recovery. The government pays $120 per person per room, per person per night in this shelter. The shelter's making, I don't know, $7,000 a night. And these people are fed one meal a day in horrific conditions. They're being robbed. Ben experienced someone who committed suicide on the side of the building, a poor soul. There's people using drugs, smoking crack on the premises. This is what our pay or its money is paying for. There's no road leading to recovery. There are murders, there's rapes, there's all kinds of really, really serious crimes and injustices happening there. And it's all happening in front of us. And it's like every time I go to talk about it, it's like I don't have the capacity to listen to that, whether it's the news, whether it's, morning show, talk shows. This is the truth and the reality of what's happening in our country, all across the country, low barrier shelters. And I can't figure out if it's an unwillingness to say, we made a mistake, we need sober living homes, or we need both, or we're just so far gone into it now, we don't know how to backpedal. I don't know what it is, but certainly I don't see integrity in that equation. When you have over 40,000 Canadians right now that have, I think it's 43,000 that have overdosed to date, that's, now we're up at COVID figures, if not more. And the willingness for people to just say, yeah, that's just the way it is. It's not adding up to me. I don't get it. Like, who's getting paid out here?
It's complicated, and there's a whole bunch of different factors at play here. So one is the ideology. Another part here is, I think, we need to ask ourselves how money is flowing and who is receiving money here. There are concerns about the quote unquote, poverty industrial complex, that you have a series of nonprofits that operate in these vulnerable communities and get constant government funding that, of course, pays lots of salaries. And in many ways, some of these nonprofit workers are not incentivized to actually solve the problem, because if they were to solve the problem, they would be out of a job.
Yeah, right? That's huge.
Yes. Now, I actually want to make a point here that is relevant to to what you described here, this kind of housing. And this is a bit of an aside, but I think it's important for us to note that we don't actually have to do it this way. So there's a guy named Dr. Julian Summers. He's based out of British Columbia. He is a distinguished addiction psychologist who is the director of the Center for Addiction, something like Karma. It's some big institute within Simon Fraser University. It's been a few months since I read the name, but he conducted a very large randomized control trial back in the mid 2010s. It was the largest publicly funded one in BC at that time, if I recall correctly. And what he did is that he sorted a group of approximately 500 homeless people or vulnerable people into 3 different categories. So one group didn't receive any special supports. They just were left to themselves. One group was put into something known as congregate housing. So congregate housing is what you described. It's when you put everyone into the same building and services are provided on site. Now, the third group received something known as scattered housing. So scattered housing essentially meant that these people were given an apartment in a normal building in a normal neighborhood. They were scattered throughout society. They were given some choice of where they could live, which neighborhood they wanted to live, and they were given services. Services were brought to them, right? It's not as if it was all on one site. And there was a strong emphasis on reintegration and employment. And so what Summers saw as a result of this RCT and as a result of the administrative data that he had access to is that when you put people in congregate housing, there was basically no benefit compared to people who were just left by themselves. Addictions remained high, hospitalizations remained high, incarceration rates remained high. Put people into scattered housing, if you reintegrated them into society and gave them employment and gave them a reason to live, to stay sober, the results were significantly better. I think like a 40 or 50% reduction in hospitalizations and crime while spending the same amount of money. So it's not that it's incredibly expensive. It is the same amount of money as we spent on these absurd congregate housing options, but we get better results. And just to close that thought, because I know I kind of monologue sometimes. But the congregate housing model, so his hypothesis as to why it is so ineffectual is that if you take someone off the street and you put them into a house, into a building where everyone is fresh off the street, where everyone is struggling with addiction, where everyone is traumatized, you are setting that person up to fail. Because
Yeah.
how can you possibly quit drugs and find meaningful employment and change your self-conception and change how you see yourself? Because that psychological component is such a big part of recovery. When people are smoking and selling fentanyl next door or down the hallway, and everyone around you is unemployed and everyone around you is addicted, you just can't. It just doesn't work.
Yeah, absolutely. And when every time I come against a wall like that, I dig further. And so I started asking questions. Well, how did this come about, these low barrier shelters? And I was talking to someone in New Brunswick the other day, and it was because, they had a homeless person who ended up, overdosing on the streets by himself. So they thought an emergency shelter like this would be a great idea. And then they built these emergency shelters. And then, of course, that ended up having all kinds of other consequences. So it seems like meaningful, well-intentioned people are looking to create solutions, but they end up doing far more damage than good, really. That's the bottom line. And when you're dealing with mental health and addictions, you either have to have a long period of lived experience, or like for someone like me who has 40 years of experience. I had a brother with bipolar schizophrenia. My son had cannabis use disorder. As a caregiver in that situation, I'm faced with it every single day. You have to, they're always 7 steps ahead of you. You have to be 9. You have to be researching it 24/7. You have to be in the conversation. You have to be looking for, it's a full-time job to find a path. And even then, the outcome may not be good because the system is stacked against you, as in the case of Ben. I mean, Ben never once got in to actually see a doctor and get a diagnosis, which is so different than like Alberta, for example, that has 24/7 when you go in and you get immediate diagnosis.
Yeah. Well, that's the problem, is that we've spent so much money and given so much attention to harm reduction that the other 3 pillars of the 4-pillar strategy have been left on the wayside. So the 4-pillar strategy, which has been popular since the 90s, is this idea that you have to focus on prevention, on treatment, on harm reduction, and on enforcement. Right. So, yeah.
I don't see this as all bad. I see this as a huge opportunity. Some of my research has led me to sober living cities. There's 30 of them emerging around the world right now. I love that idea because they address the systemic side of it. It's, federal, provincial, municipal, combined with a combined goal and vision, in the same way that we've become inclusive with disability, for example. It's architected around that same framework. And to me, that's a smart idea. And also the opportunity to make sober living cafes, sober living villages, sober living homes and communities. And from the research that I've come across and all the psychiatrists that we've had on the show, they will say the first thing is community. And the second is, having lots to do, lots of purpose, lots of self-expression. That person is wanting a lot of energy, wanting to be able to, be a productive member of society and do what they love to do. Mm-hmm. So just like anybody else, I mean, how hard is it for us to build that? I think we've so overcomplicated this whole thing.
I mean, it's complicated. There are certain simple elements. I mean, yes, we should encourage more sober spaces, right? Because how are you supposed to maintain sobriety if you have no place to be sober, if you're surrounded by drug use? And that's an important piece of it. But I mean, once again, addiction is also very complicated. There's a lot of moving parts, and that's what makes it so contentious. For example, like, let's talk about pain patients, right? And this is this may seem like a bit of a digression, but the underlying reason why we have an opioid addiction in North America to begin with comes down to how we treated pain.
Right.
So basically before the 90s, opioids were very seldomly used. They were never really used in healthcare. They were reserved for people like the most extreme cases of chronic pain. We're talking about cancer patients who were near the end of their lives.
Yeah.
And then, of course, you had Purdue Pharma, which was an American pharmaceutical company, and they wanted to make a lot of money, and they had a slow release opioid known as oxycodone, which was marketed as OxyContin. And they told everyone that it was safe and that no one got addicted to it, less than 1%. They misrepresented existing research. There was barely anything. And they told everyone it was safe. They misrepresented research. They seemingly bribed a high-level official in the FDA, and oxycodone suddenly flooded into communities, and everyone got addicted because, this safe pharmaceutical drug was really not that safe. And then they financed an entire network of nonprofits, which then advocated for the normalization of opioid prescribing, the American Pain Foundation, the Appalachian Pain Foundation, things which sounded really nice on the surface level, but really were just industry fronts. And so doctors were flooding communities with opioids. They were told that they were opioid phobic if they didn't do this, that they were neglecting their their patients, that they had to be compassionate. And then eventually we realized that we had screwed up, and we realized that we'd been lied to. And so Purdue was fined billions and billions of dollars, and opioid prescribing was cut down upon. But what did that do? Well, all the people who were already addicted to pharmaceutical opioids then transitioned to heroin because they saw the addictions there, right? And so then we have a heroin epidemic because we cut off the pharmaceutical prescribing without thinking what our transition plan is. Because you want to stop the new addictions, but you also have to think about what to do with the existing population of addicts.
Yeah.
And then on top of that, in Canada, so we have now cut down on opioid prescribing, but we haven't invested into other forms of pain treatment. So we don't have, significant coverage for physiotherapy or for psychological support for managing with pain. And so many people who are in chronic pain will end up just relying on opioids and then getting addicted and then adding to this population of addicts. So once again, like that using that example, we can see how there are a lot of very different interconnected parts.
Yeah.
And every solution, most solutions have trade-offs. So you have to be very careful about the trade-offs. And it's not an easy fix.
I mean, when I think, for me, the fix is just look at what happened to Ben and every single loophole that he fell through. Well, I took him to the hospital many times. The privacy law allowed him to walk into the hospital and say, yeah, I'm doing great. You could have told him he was going to jail or he was going to Tim Hortons. And for some, Ben did not have capacity. So it's determining capacity up front, no matter who it is, as soon as someone presents with a problem. And like Alberta, 24/7 system for early diagnosis. And then they are now investing in therapeutic sober living homes and facilities, I think, without wait times. So ABC, that's the basics of where we need to be. I mean, here in Newfoundland, you can't even get into detox. It takes weeks, if not months, to get into rehab. Like, it is horrific. People are dying, as they're waiting. And then if they relapse, they're dying when they get out. So, I mean, that's set up to fail at every juncture. But I would just like to take even half the money that's going into, low barrier drug den shelters and the hydromorphone supply and put that into recovery. I think we'd be so much further ahead. It's not the answer to everything, but and also changing the culture of recovery and making it, because I think addiction thrives in the dark. And when people don't want to talk about this stuff, it has the capacity to thrive like a virus. So, like, let's make it mainstream. Let's talk about it the way it is. One of the most powerful programs that I found on the internet is called 24/7 NA.
Mhm.
And that's every single minute, every single hour of every single day. They have NA online. And you can go on there and listen to 150 people at a time, usually from all over the world, their wisdom, their insight, their lived experience, and, their 12 steps. So they're following the 12 steps. Their whole, premise is no drugs whatsoever. And boy, that's one of the most, I can't turn it off. It's like the best thing I've ever heard. I listen to it like I listen to the radio because it has educated me so profoundly by listening to people who have overcome this illness that I think it's the best teacher we have. It's those types of things that are going to save the day.
But I think we need to have mechanisms in place to force people into recovery. So you mentioned, well, I think you've been alluding to over here, involuntary treatments.
Mm-hmm.
One piece. Well, actually, you know what? Let's take a step back. So there's really two tasks here. So first of all, how do you build the treatment capacity so that you actually can provide treatment to people if they want it?
Yes.
And some people will go voluntarily, but then there'll be a population that won't go. So the people who won't go voluntarily, how do you divert them to use that capacity? So in Canada, we are currently having a conversation about involuntary treatment for people who are severely addicted to the point where they obviously cannot make any decision for themselves. But do we necessarily have to wait all the way up until that point? It's a bit of a shame. And this is where we can talk about the Portuguese model of decriminalization. So decriminalization in Portugal is very often misunderstood. Many fans think that they just let people do whatever they want, and if we do the same thing, it'll be great. No, it's not what happened. So in the years preceding decriminalization, Portugal invested substantial amounts of money into building up treatment capacity. They used a lot of EU funding for that and essentially made it so that when they decriminalized, that recovery-oriented services were well-funded and widely available, and there were very few wait lists. Now, when they decriminalized, they didn't do what BC did. BC basically just said, do whatever you want, and if we catch you with a small amount of drugs, we'll maybe give you a flyer that can educate you about where to seek treatment, which is incredibly condescending, as if these people don't already know about these options to a certain extent already.
Right.
Yeah, like, I'm sorry, anyone who's dealt with addiction, we know that it takes more than just handing someone a flyer. Otherwise, every family would be handing flyers all the time.
Yeah.
So what Portugal did is they realized we can't just arrest our way out of addiction. Someone who's addicted, you can't just throw them in jail. It's not going to fix everything. And it's not productive. So they created an alternative system of justice that existed outside of the traditional justice system. It was non-criminal. So if you were caught using a personal amount of drugs, you weren't just let go. You were basically summoned to a drug commission composed of a psychologist, a social worker, and a lawyer. They would review your case and they would pressure you into seeking treatment if they felt like that was appropriate for you. And they could use fines and other sanctions to do that. So there were mechanisms in place to meaningfully divert people into treatment. And as a result of that, many people sought treatment. And oh, sorry, I interrupted you. Sorry.
Well, no, I think from what I read, it's like you have a choice. You can either pay a major fine, you can go to jail, or you can go to rehab. And consequently, that the choice continues to be all roads lead to the choice of rehab.
Yeah, everything. We are basically we're coercing people into rehab, which is great. And then for like HIV levels dropped off, overdose levels dropped off. The overdose levels, though, they were kind of exaggerated, the drop off, because they switched how they measured data halfway through, which I learned from a Swedish researcher, where apparently like no one in North America knows. But still, even if you use the same methodology, you had a big decrease. And Portugal saw really great results up until 2008. And then in 2008, the big recession happened and budgets had to be cut. And of course, recovery services were cut, so they were no longer available. And then over time, overdosing deaths started to go back up, which reinforces the importance of having treatment and recovery. And then another thing is that in Portugal, their early success, which was treatment oriented, got undermined because the state, no longer having the funding to provide these services itself, ended up outsourcing a lot of its work to nonprofits. And these nonprofits focused on harm reduction, where they just enabled people and gave them whatever paraphernalia they wanted without actually pressuring them to recovery. And now Portugal is looking into undoing drug decriminalization because they essentially accidentally ended up with the BC model rather than their initial successful model.
Good to know. Yeah, because there's so many differing conversations about that. I presented to the premier what I feel is the best recovery model that I could come up with based on my experience. And my solution was to get rid of the word involuntary altogether. And so that we basically had one simple model. That person either has capacity or they do not. Most people don't know that 40% of people with bipolar, 80% of people with schizophrenia have what they call anosognosia. Anosognosia is a brain illness that doesn't allow you to actually see that you're sick. And when I look at our homeless population, that's what I see. That's what happened with Ben. If Ben went to the hospital, he would never say, I'm sick, or I have an issue, or I have a problem. It was just like he could see it in others perfectly, but not himself. And anosognosia is so common in the mental illness realm that we just simply do not diagnose it for it. So if we have a system where it's, does that person have capacity or not? If they don't, then it's not involuntary treatment. It's treatment just like someone with dementia.
Yeah.
And the testing for that can be done by asking physical questions, or if there could be physical or neurological exams. And there's diagnostic testing and imaging in the form of CAT scans, EEGs, and MRIs. So we have the tools and instruments to determine whether or not someone has capacity up front. And we don't have anywhere where people say, oh, they have addiction. Okay, let's get their brain scanned first, see if they have anosognosia, see if they have capacity. But we do that for dementia patients. And our society, the stigma, the conversations, it's like, oh, that person has addiction. It's either they'll be fine once they sober up, or addiction is a choice. So they're choosing to have it that way. And we're sitting in the fallout of that very rudimentary thinking, and I don't think it's serving us. Yeah. That's my 2 cents worth on it.
Well, I think most Canadians would agree. Most Canadians can see that if someone is severely addicted and tweaking out on meth, or constantly nodding off on fentanyl in the streets, that they don't really have a free choice over themselves. They don't really have any capacity to understand what's best for them. But the problem goes back to the thing that I mentioned earlier, where a lot of addiction policymaking is driven by these drug user activists. And so for them, if you suggest that drug users may not have the ability to understand what's best for them, they view that as being deeply offensive and paternalistic. And they say that you're the bad guy. They say that you're evil, you're stigmatizing them. They'll do anything to minimize the harms of addiction, when everyone else can see the obvious, which is that someone who is severely addicted needs to be thrown into treatment regardless of whether they want to. And sure, involuntary treatment is less likely to succeed than voluntary treatment. I don't think that's shocking to anyone, right?
Yeah.
But it's better to put someone in involuntary treatment, even if it's less successful, rather than to leave them on the street to harm themselves and others. Yes, it'll take multiple times, multiple efforts, but we need to make that investment rather than abandon people to death.
Yeah, which is so inhumane. To me, that's murder. I see it at that level. If we are leaving all these people, we're to I don't know. It's, to me, so inhumane. It's just, I can understand, like, there's some people who want to stop the harm in the very short term. They want to kind of help that person not overdose today. But that to me is such a short-term vision compared to what's actually possible. I don't know. What's the answer to this, Adam? Like, we've got so much experience and understanding. Like, why doesn't Canada have their shit together with this?
Well, I mean, there's a variety of different things at play here. I mean, one is ideology. Many of our, once again, the addiction policymakers who are in charge here don't really think that recovery is possible for many people. Hence, they're really gung-ho about enabling drug use and eventually seeking out drug legalization. That's their thing. So they obstruct the conversation. I think that they need to have their influence diminished, and we need to go back to recovery. And I think that the political winds are sailing in that direction. I think we need significant investment into recovery capacity, as well as legal mechanisms to divert people into using these services, whether it be through a Portuguese-style drug court or through involuntary treatments. But on top of that, let's say, for example, I'm going to talk about safe supply again. So I'm very critical of safe supply. I think in the current form, it's an absolute disaster that is obviously making the situation much worse.
Yeah.
Is there a role for it? Sure. I think that if you provided safer supply in a strictly supervised setting, like you do with most methadone, right? And you used it as a temporary measure to help people titrate, which means adjust onto methadone or Suboxone, which is a traditional evidence-based addiction medication.
Yeah.
Sure, why not, right? Because actually, let's take a step back. So, historically, we've treated addiction with methadone, Suboxone. What are these drugs? Essentially, they're long-acting, weak opioids. So you take it once a day. It's just strong enough to manage your withdrawal, but not strong enough to get you high. And then slowly get you off of it. Now, because people started taking fentanyl is much stronger. People's tolerances get much higher. So it takes longer for them to get onto the right dose of methadone or Suboxone. Opioid agonist therapy is what it's called, OAT. And so OAT is less effective because it takes longer to initiate it, which is why people say, oh, give them safe supply because OAT doesn't work. But OAT does work. So you use safe supply as a temporary measure to get people onto OAT. That makes sense. But that's not what we're doing. But that's something we could do. Why not? And we could even offer safe fentanyl under tightly supervised settings. That would help people get onto OAT.
Yeah.
Now, another piece, which is really often missing. Oh, sorry.
Before you go on to the other piece, like in the case of Ben, he was on Suboxone and doing coke and blue canoes and like, so our system is really failing him in the sense that all these doctors that are allowing this to happen and our infrastructure that doesn't have any support or accountability just basically were, exacerbating his death.
Well, that's the thing, right? The quality of care drug users receive is really low. And with OAT, and this is a thing that we need to fix as well. So methadone was first pioneered in the 60s and 70s, and initial research showed that it was highly effective when paired with psychosocial supports. So you use methadone to stabilize someone just enough so you can go and give them the psychological help, the employment assistance that constitutes the bulk of recovery.
Right.
And these researchers actually cautioned, they said, if you just provide methadone without the additional supports, it's not going to be effective, right? And so Richard Nixon, he heavily invested into methadone clinics, which was good, but they didn't invest into the additional supports.
Right.
And in Canada, we started using oats, so methadone, a lot in the 90s. And like at first, we gave decent levels of support. And then starting in the 2000s, because the government would pay you for providing oats because it was stigmatized and people didn't want those patients. So Government paid more. It created a financial structure where many OAT doctors basically tried to profiteer. So they saw their patients for as little time as possible. See your patient for 5 minutes. Don't offer them any psychosocial support. Don't check in.
Yeah.
Really just churn them through like a revolving door. Maximize your urine tests because you can charge for all of them. And
Yeah.
they were making as much money as possible while the quality of care nosedived.
Mm.
More recently, they've tried to improve OAT by doing these rapid access clinics, which are more holistic, and we need more money into that. And we need to make sure that OAT, as another, as another form of combating addiction, doesn't degrade and become shitty in the way that it has been in many jurisdictions and in many periods of time in Canada.
Yeah. Yeah. Fully agree. I mean, you're so smart. You definitely know your stuff. Well, I don't know. I mean, change government, first and foremost, change philosophy, change of fundamental beliefs, change of system, change of systemic system. And then, like all these nonprofits, like even the social services, one of Ben's social workers said, like, it's my experience that people who go on social services never come off. And I was like, immediately when she said that, I knew he was doomed because he was in a system that believes that you're never getting out. And same thing with his doctors and even our leadership here. Well, we can't tell doctors what to do. Yeah, we have to tell doctors what to do, because if we don't tell doctors what to do, more and more of our people are going to die. And when I look out into the future with the status quo, like, it scares the heck out of me. How about you?
It does. And going back to telling doctors what to do, we have to keep in mind that many of the doctors that are working in addiction medicine, not all of them, but many of them now, don't actually have addiction medicine backgrounds. And this is going to go back to the safe supply thing. So with safe supply, the federal government funds a few pilot, like key programs that provide safe supply scattered around Canada. But those programs don't actually service a lot of people. They're kind of like the spine of safe supply. But for the most part, safe supply is prescribed by nurses or regular doctors who are interested in it. So let's say you're struggling with addiction, you go to your family doctor, you say, I'm addicted, and they have the ability to prescribe you safer supply drugs. It's basically just label prescribing, because they say, sure, why not? And many of them have heard good things about safer supply because they read these low quality studies, or they're kind of misled by these activists. And the federal government incentivizes them to experiment with safer supply by providing funding, by providing positive messaging. And so these doctors who are not addiction specialists will then provide safe supply, which only makes the situation worse, while the addiction doctors who actually are the specialists say that this is disastrous.
Yeah.
And so, like, this is a situation where we are telling the doctors what to do in a way, and we are telling them the wrong thing. And we need to fix that and tell them not to do this thing, which is making the situation worse.
Yeah, precisely. That's bang on right there. Is there anything else that you would like to get out in this interview? We're almost finished up, but this is a fascinating conversation, and I hope to have more conversations like this. I'm also so interested in what you have to say about Ukraine, and I love the fact that you are just a warrior for the world and focused on, I just wish the whole world would think like you. It's like, what's wrong in the world? Well, this is what's right in front of our face. Okay, let's go work on that. If we had, if our populace thought that way, man, the world would be a completely different place.
Well, it's very nice of you to say. I'm glad to hear that my work is appreciated. I would have tons of more stuff to say, but I mean, it's such a big subject. We only have so much time. I apologize if I talk too much. I tend to do that, but
it's fantastic and very, very educational. Just before we go, like, what's the sort of most astounding thing that you've seen, that you've written about in the last number of months, that you want people to know?
Well, a story that comes to mind is this former gang member who I interviewed a few months ago. He was a teenager. He's part of the gang, and he told me all about the diversion that was taking place with Safe Supply in Vancouver. He would sell it. He would sell it to his friends as well, and his back in Port Coquitlam, which is 40 minutes outside of Vancouver. He would sell it to all these youth.
Yeah.
And for me, it was just awful when hearing his story and realizing the extent to which organized crime is profiting off of this program, which we are paying for with our own money, with our taxes, and how criminals, in a sense, are laughing at us because we are supplying them with cheap opioids that they are using to destroy people's lives. It really just encapsulated everything that is so pernicious about our current addiction crisis.
Yeah. You can sum it all up in that one package. And here you have these 14-year-olds. And that's what I saw when I went to Edmonton, to Tent City. It was like little boys, 9, 10, 11, on bicycles selling drugs in the Tent City area. And I felt like I was in a war zone. Like I had never, ever seen or experienced anything like that in my life.
Yeah, it's insane.
This is who we've become, but this is not who we are. And thank you for helping us turn it around. It's so important.
Likewise, thank you for starting your organization and for being part of the fight.
Well, come back and have another chat with us soon, and we'll get more into it, and we'll follow your stories in the National Post, of course. And keep us abreast, and we hope to work with you a lot more in the future, because I think you have your head on straight. I think you have your facts down pat. I think you're super smart, and I think you're a good visionary. Okay, so for our listeners, if you want to read more of Adam's articles, be sure to check into his column in the National Post, and in most interesting articles there. We remain committed to uncovering the stories and challenges shaping our world and transforming addiction into recovery. I'm Tina Olivero, your host of Guardians of Recovery podcast. Tune in with us again. We'll see you next time. Over and out.